media friends for the first time. So thank you so much. I won't, before I start, I just want to supplement for what my colleagues has mentioned regarding the Nikshe Mitra, the donor. So who can be the donor? Any individual, any NGO, anybody. So the main objective, which I want to mention, the main objective of this Nikshe Mitra for nutritional support, the main objective is not only for nutritional support, but the main objective is community involvement. Community involvement, so that to reduce the discrimination. Because once we get a donor, what we do is we register them, we search the patient. After that, we link the patient to the donor. We give the names and numbers of the patient to the donors so that they can call up the patient, they can encourage the patient. That involvement is there. So now the patient thinks that, oh, that the feeling of that stigma or discrimination will reduce. So the main objective is that the community involvement to reduce the stigma or discrimination. So that is what I want to mention. And for the donor to support, there is a recommendation by from the ministry, the recommendation of foodstuffs. So it can be they have given in kg, gram, like that. Chana this much, dal this much, oil this much. So, but then it depends on the donors. So now what we receive from some donors is that a packet of dal, kg of chana, set of eggs, oil, and sort of. And then one donor which she is supporting 10 patients. So she is not giving the support according to the recommendation, but it's up, what I have said just now is up to the donor. She is giving the best foodstuffs again, like the supplement, which is very costly, actually 1,000 something types of supplement with dal, with egg, like that. So it's up to the donor. So any can be a donor. So that is what I want to supplement. And just briefly, I want to share about the latent TB. Latent TB is also, in other term, it is also called hidden TB or inactive TB. Latent TB. So what is it? We all know that India is the highest estimated TB burden globally. TB infection, latent TB infections globally highest. So nearly 35 to 40 crore of Indian population, they have latent TB infection. So out of which 26 lakhs they develop into active TB in India. So what is this latent TB? So latent TB is the presence of TB germs, in layman word, TB germs, which is Mycobacterium tuberculosis in the body, which are dormant, asleep in the body. So these TB germs, they can remain dormant in our body for a long time, even decades also. So I'll come into that later. So what is the difference between the dormant, the latent TB or inactive TB and active TB? So latent TB or hidden TB or inactive TB, it has no symptoms. They have no symptoms. One. Number two is they cannot spread to others. Number three is, even if we send do the X-ray also, the X-ray will be normal. If we test for sputum by microscopy, by CBNet, by TrueNet, the result will be negative. So in case of active TB patient, they have symptoms, like what my colleagues has mentioned. The patient will have cough, that hemoptysis, the night sweat, fever, chest pain, fatigue, loss of weight, no? Loss of appetite, those symptoms they will have. And they will spread the infection to others, active. And if you do the chest X-ray, the X-ray will show normal. If you do the microscopy or sputum test, it will show positive. So the difference between the inactive latent TB and the active TB is that which I have mentioned just now. So can latent TB develop into active TB? Yes, because 5 to 10% of those infected with latent TB infection, they develop into active TB in the course of their lives. Usually, in the first 2 to 5 years of that initial infection, so it may develop. But the germs is in your body, but it is not developing. Why? As my colleagues has mentioned, it's because of the immune system. They are in the germ is in the dormant phase. It is because the immune system, the person's immune system is preventing the germ cell to grow, multiply, and develop into active TB. So it is the immune system only. So immune system it plays the important role, because immune system is a defense system. Now our defense system only. Any kind of infection, disease, TB, maybe COVID or anything, our immune system is the one only that which prevents them to become active. So that is the one. So how can we stop, or how can we prevent latent TB from becoming into active TB disease? So number one is by finding and treating latent TB infection amongst the that is number one, through active case finding amongst the high risk population. So that is extremely very important to NTB and also to achieve TB elimination. So the active case finding among the high risk population by treating and by finding and treating the latent TB infection. So to prevent to develop active TB disease, we give TB preventive treatment. So my friend Keto will speak on the TB preventive treatment. So thank you so much. If there is anybody, we can discuss later.
Introduced to us, I believe now, which is called the latent TB infection. So the argument here is, instead of, or rather, waiting for people to get sick and then get treatment, admitted in the hospital, undergoing the chest X-ray or the ECG or all those other complications. Though it's curable, why not avoid all those in the first place by treating it before it starts to make the person sick? So prevention is always better than cure, is the logic that this TPT is trying to emphasize upon. Just to also bring a little bit reflection about the inactive TB, the TB germ that you and me might be having even as of now is. I think in this room we are around 25 of us. On a very rough scale, I think maybe on a very rough scale, okay, 10 of us might be having the latent TB form of infection. But by the grace of God, no one of us are sick. We are still healthy, we are still alive, we are still with good appetite, we are still with good health. But we never know. It can be me, it can be you that is with this latent TB infection. But as the days progress, if our immune system is being compromised because of various reasons, such as we have discussed a little bit about diabetes, someone who is into too much of smoking, or it can be other comorbidity kind of an infection. Example was HIV that was also brought into the reflection. So as of today, I or you or any one of us might be having this particular latent TB infection. one day it will progress, likely that it will progress into the active form of TB. That is where we need to go to the district TB center, meet Dr. Chipan, undergo the series of diagnosis, undergo the lengthy treatment duration. And I will be very frank out here also to say that TB treatment is possible, but it's not very easy because the treatment drugs are a whole combination of 4 drugs. Even if we talk about the drug sensitive form of the TB, it's 4 drugs and it has side effects and some long-term treatments which are of the multi-drug resistant form of TB. It has even the capability, the potentiality to make the person go deaf also. So rather than undergoing through all those turmoil, why not we prevent the latent TB infection in the first place from progressing to the active form of TB by treating it? So that is where we are about the importance of TB preventive treatment. So what is TB preventive treatment? It is also a treatment through a certain duration of treatment course through different approach of treatment regimens. And of course, it is also free. And the preference is also initially was given to the community of people living with HIV, which Lano will discuss more on the point of the co-infection with HIV. But still, that was how initially the program was rolled out. So we have the active TB, we have people in the category who are with the latent TB. If we don't treat them now, they will progress to this, and the caseload of active TB will always keep on increasing. So treating them at the district TB center, also in coordination with the AIDS control program, is something that the national program policy makers have formulated the treatment guidelines. And as of now, we have one particular treatment strategy which is called, I'll just be very slow here because this kind of gets a little confusing also, a little technical or medicalized. Now I'm not a doctor, but still. So this this strategy, what we have as of now is through a particular drug treatment approach called isoniazid. And isoniazid also is a drug which is used to treat the active form of TB, as has been mentioned by Dr. Roko. But this particular drug also is being used to treat people with latent TB infection before they become sick. So isoniazid is the drug that was used to treat, that is used to treat anyone who is been having or likelihood of having the latent TB infection. The program is called isoniazid preventive therapy. In short, we say, or rather the program say IPT, isoniazid preventive therapy. So IPT was made available, I believe it was 2017. I'm not very sure about that, but it has been with us for 17. It has been with us for a couple of years. Now, let me also bring a little bit about the reflection in the challenges. Isoniazid preventive therapy to treat the latent form of TB is a lengthy treatment in itself again. It's a 6 months course. It's a 6 months course. One single pill a day for 6 months. So if we calculate into the average number of days in a month, 30, 6 into 30 becomes 180 days for the treatment course to be completed. Now, those people who are supposed to be undergoing this isoniazid preventive treatment, or we can say isoniazid preventive therapy also, I don't know whether it's the misconception or rather their understanding. Their understanding on this is that, I'm not sick. I'm not sick. Why should I undergo a medication course for 6 months? Why is the doctor giving me this prescription for 6 months? Now it's free, and they have given me a quota of 1 week or 1 month as a take home, and I can comfortably take it at home. But I'm not sick. Why do I have to undergo a 6 months treatment therapy for TB prevention? So the level of awareness leading to that kind of understanding results in the people not actually wanting to come out much into taking this IPT program. So that is basically one of the challenges that we are seeing. But the challenges will also magnify more in the context of people living with HIV also, which again Lanu will dwell more on that. But the national program also is now has realized that. Okay, I'm not just saying it. The national program has also acknowledged and realized that it's a lengthy treatment duration. Therefore, in order to upscale the intake of TPT service, the treatment has to be revised. The duration has to be shortened. From 6 months, it has to be shortened down. Now, I've just circulated one piece of information to our President, Alice. In that, if you all get a copy of that, I've not deliberately bring the printout, okay? Just the soft copy. So in that, if we look at that, now the WHO, the World Health Organization, has come up with certain TPT treatment regimens. It's not only IPT for 6 months. In some countries, IPTs are being given for 9 months also. But more than that, the preference is a better short course regimen. So, not only IPT for 6 months, but now there are, I believe, 6 treatment regimens. But we will not discuss all those for today. What we'll discuss is the one which is made available in India in many parts of the state, and the one which our state will very soon have. They or me cannot commit when, but the drug has arrived in Nagaland. So now the modalities of how to make it operational will be worked out, of course, by the department, and then that new treatment regimen in the form of a shorter course regimen will be very soon rolled out. So we will be discussing on IPT only for today, and also the other regimen which I am referring right just now about what we will be having very soon is the treatment regimen called 3HP. Okay, 3HP. Now, what is 3HP? The 3 stands for 3 months treatment course. Okay, 3 stands for 3 months treatment course, and H stands for the acronym of the drug called isoniazid. So 3H, and P stands for the name of another drug called rifampicin. Okay, so those drugs are being mentioned over there also. So we need not worry about the spelling or things like that for now. So 3HP is 3 months with isoniazid and rifampicin. So it's a combo drug now. So I will just give a comparison about IPT versus 3HP. Okay, so IPT is one drug with isoniazid for 6 months, whereas 3HP is 2 drugs with a treatment duration of 3 months. Okay, but in this, the 3 months treatment duration does not mean that it will be a daily medication. It will just be a one single dose per week. So all in all, I'll just be slow here again. All in all, there are 4 weeks in a month. So every week, if I have to take 1 dose, it's 4 doses only in a month. Into 3 months means 12 doses only. Okay, so 12 doses. So here we have IPT, which is, I said, daily dose for average of 180 doses, as in days. Here we have 3 months course with a dose of only 12 weeks, as in one dose for 1 week, for 1 dose in a week. That means it's just 12 doses only. So this is 3HP is a shorter course regimen. So therefore, the argument is not condemning the IPT program for now. because that was the only option, and I believe that that option also still should be made available. The people has to give informed, has to be given the proper knowledge and should be given the liberty to make informed consent and take informed decision whether they want to opt for the IPT program course or they want to opt for the 3HP program course. Because 3HP also comes with another drug. Like I said, that rifampicin is there. And if we talk about rifampicin, this also is a TB treatment drugs only. And then, just like any other drugs, even paracetamol, for that matter, even the HIV treatment drugs, for that matter, just like any other drugs, these TB treatment drugs also has side effects. Therefore, these drugs that are used to treat the latent TB form of infection also has side effects. But those side effects usually outweighs the potential benefits, which means if someone don't undergo this treatment, fearing the side effect or fearing other reasons like distance or I don't want to go there or the social stigma that we have been discussing, because of all those, if anyone who is likely to be having the latent TB form of infection does not undergo either the IPT or the 3HP TB preventive treatment, then it's very likely that he or she might progress to the active form of TB within a month's time, within couple of months, or even depending on the person, the immune response of the person. So those are the thoughts that is coming into my mind. Just to also bring a little bit about the reflection, who all are eligible for this? Now, like I said, out here, 10 of us might be having. If we go to the old MLA junction, for example, for now, 200 people, just giving a very rough number, okay? 200 people might be just moving around. So out of those who may be having LTBA, we don't know. But who do we test? That also we don't know. Can we test everyone? That is not possible. Because testing is to do with some other medicalized form of lab investigation. So, and it's absolutely not very necessary to keep on testing everyone. So the program is now thinking on narrowing down its focus to a certain group of population, not randomly to everyone. Okay, like the best example I could give, in fact, COVID has taught us a lot of things. The best example that we could interpret through this is the COVID experience, where the contact tracing word was used, right, in COVID. So if I'm with COVID, and he is my brother, she is my sister, we all stay together in this room. Then if I'm with COVID, then they are my contact tracing, so they undergo the COVID test, she also will undergo the COVID test. That is what was done in the war against COVID. Similarly, in this war against TB, let me just use the word for now, war against TB elimination, if I'm with TB, then it's very likely that since we are staying together, they might have got the infection from me, like doctor mentioned, that through my droplets, because we interact with each other, we stay together under the same roof, eat, sleep, interact together. So if I'm with the active form of TB, my TB bacilli, the germ, might have been floating around in this room, and she might have inhaled. So they are we don't use the word contact tracing out here, but they are my household contacts. HHC ko na household contacts. So they are my household contacts. So if I'm with active TB and undergoing the TB treatment, they might have got exposed to my TB germ. Therefore, they are my household contacts. So they will be given the IPT or the 3HP. Okay. So similarly, people with HIV, people with diabetes or any sort of immunosuppressed form of a health condition are supposed to be given this TPT, whether it be IPT or 3HP. The program, of course, also has to focus on ruling out. This point is a little confusing, tricky. For anyone to be initiated on TPT, first, active TB has to be ruled out. Active TB has to be ruled out. Because if that is not done, then we will be giving the TB prevention treatment to someone who is already sick with the disease. So that is the wrong approach. So TB nai kwenehe confirm ho lage. TB has to be ruled out first. If in the process of the screening, if any sign and symptoms of TB has been found, has been detected, then that person might have to undergo the various diagnoses that has to happen, and following that, if found to be with TB, then the TB treatment should happen. So ruling out active TB is very important for anyone to be initiated upon on TB preventive treatment. So how do we rule out TB? Is through some tests, of course, but I don't think the program can go into that extent, nor I believe that is very required, because WHO also has said that wherever it is possible, other than that, in many settings, because we are talking about blocks, villages, urban, suburban, rural, all those nooks and corners, we are talking about all those things. So wherever possible. So how to rule out TB in anyone, in any person before initiating that TB preventive treatment is through the verbal screening. The program call it 4S, right? 4S. So if anyone who is a household contact exposure comes to the TB center, then the doctor or the nurse or the staff out there will interact, counsel that person and assess whether he is having any sign of TB, as in bukhar ase, kashi guri ase, night sweat, loss of weight ase, loss of appetite, all those questions. If any of those answers are yes, then likely TB may be there. But on the other hand, if those answers are all no, 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 that person is not having fever, no cough, no night sweat, no loss of weight or loss of appetite, then TB is likely that is not with him. Active TB is not with him. That means he can be initiated on either IPT or 3HP. So those are some things that I just want to highlight. I know it's a very big topic and it sounds confusing, and even the national program, or rather in our state also, we have not discussed much. So I don't know how far of a justice I have done by trying to explain it, whether it was simplified or very complicated, but I think just to give a last comment before I conclude is that just repetition only, in reiteration only. TB, active TB is there. Before that, latent TB is there. Before the latent TB starts making you sick, why not treat it? That is the argument. That is the rationale behind TB preventive treatment. And where can it be treated is, of course, in the district TB centers, which are attached to the district hospitals. And who can be given is something that we have discussed. Children below 5 years of age, the household contacts, and anyone with immunosuppression form of health condition can be initiated on either IPT, but better advocacy needs to be emphasized on introducing the 3 months regimen of isoniazid and rifampicin, 3HP. That is something that I want to share out to all of you. Thank you.
Without any medication for the last 10 years, after knowing my HIV status. But for TB, though, if we cannot start for 10 years, that means I don't know we can survive. So I think once detected TB, I think we have to treat the treatment first. And then why it is important for our this thing, IPT is important because being from the HIV background, TB is the main killer. Because like whenever our immune system goes down, that means 90% of us will be TB. So like in order not to have this thing TB, we were put into this IPT. Now it's good news that for 3 months course,
Yeah,
3 HP has come, so it will be very good for our community. But there is this thing also side effect for this IPT. Especially I don't know for non-positive, but when it comes to positive cases, there will be some dizziness and then skin rashes. So like dizziness, it's okay. Like they will consult the doctor and then the doctor will continue and then it goes off. But when it comes to this thing, allergic, it's very, again they ask the patient to challenge again to take again, but it's becoming bad to worse when it comes to allergic. So they have to stop the IPT. And then sometimes because of bill burden also, they on silly ground said itu kali itu mata pikai, pet pikai, pula itu kun pikai, something like that. Excuses are also there from our community. And like it doesn't mean that I have taken IPT and then I will not get TB. No. Even if I take IPT, I'll get TB also. Especially for those, we used to term them as miscase and LFU. Miscase means those who have lost their medication, that means ERD drugs for 1 day to 3 months, we used to address them as miscase. And from 3 months onward, we used to term them as LFU, lost to follow-up. So like those people who are on ERD treatment and they have missed the drug and for 3-4 months, 7, some of them even up to the 5-6 years. When they come again, they have to retest all this thing. So in some cases they have detected TB also. But when they have taken IPT, the result is good. Good in a sense like recovery is a little bit fast if they take IPT. That's what I'm not an expert also. I'm just sharing from my experience. And like during discussion we will share, but I just wanted to request to my fellow people living with HIV that please let it be whatever. There may be some side effect like Sir Ketu have already mentioned. Even if you take paracetamol also, there will be some side effect. But please, I request all the people living with HIV that to take IPT, because if you don't take IPT, that means one day it will be you will not die of HIV, because our main killer is TB. So there is a request that I want to say to my fellow people living with HIV.
Colleagues, members of the press fraternity, and friends and colleagues from other partners or angels of TB program. First of all, a very good morning to all of you. And at the outset, I would like to thank the Almighty for giving us this beautiful day. And I also would like to thank you all for the help and support which you have been extending to our program. And I hope that your support will continue in the days to come also. Today we are here to talk about TB, and briefly I'll tell you about the concept of TB as well as the TB control program that is taking place in our state through the national program. As we all know, TB is not a new disease, it is a very old disease. In olden days, there was no cure for TB. But with the advance of medicine, TB was curable. So in Western countries, TB was almost eliminated. But then with the advent of HIV pandemic, TB again became a problem. So with that, if you look at the world scenario, it is said that 10 million people are being affected by TB every year, 10 million people. And in India alone, we contribute 2 millions of TB per year. So if you look at TB scenario, it is something which is a very big burden to our people, as well as to our economy, our finances. So with that, government has come up with the initiative of National TB Elimination Program. Because we are spending so a huge resource of our finances on this aspect because of treatment of TB. So now that TB is curable, the government of India thought that TB can be eliminated. So the World Health Organization has targeted 2030 for World TB elimination. But the government of India thinks that with too much of TB cases in India, it will be too late if we wait for the global TB elimination. So 5 years ahead of global TB elimination, we are planning to eliminate TB by the year 2025. So with that concept, even Nagaland also now, we have gone into full campaign mode. Previously, what we do is we wait for the patient to come to us so that we can diagnose them and treat them. But now we are going house to house, door to door, in search of this active case finding. We call it active case finding. So now with only a few more years, another 1.5 years to go for world for this TB elimination in India, we are in active campaign mode. So to come to this TB specifics, I'm sure that all of you must have read it in papers or must have had conference like this or in some seminars heard about this TB, what is TB, how it is spread, all these things like that. TB, as we all know, it is a respiratory disease. It is a acute infectious disease. It is caused by droplet infection, just like what we have experienced a few years past, COVID pandemic. It is spread through droplet infection. So that's why it is very dangerous. If you look at HIV, it is spread, the mode of spread is different. So we can control. But TB, it is spread through droplet infection. So no matter how careful you are, unless we try to reduce the case of TB or we eliminate TB, there is still chances of us getting TB since it is a droplet infection. So TB is caused by droplet infection, and once a case of open TB case, that is pulmonary TB case, if they coughed out, like here in a meeting like this, if a person with a TB coughs out, since it's a droplet infection, he expels the bacteria into the environment. And anyone surrounding that can inhale that bacteria. It goes inside our lungs, and depending on the immune status of the person, TB can develop, TB can start in that particular person. So I'll go into detail later on how this mechanism comes about. But that's to do with the spread of TB. It is a droplet infection, and after this infected patient coughs out, that's how it spread in the environment, and it enters our respiratory system, and there it gets lodged. And there it stays there in our body. Later on, that's the concept of TPT, okay? All of us at one point of time, we are exposed to this TB bacilli. But all of us do not develop the disease. Only certain people develop the disease that is called tuberculosis. But many of us, we do not have the disease, but we have the bacteria inside us. So it is that very concept. Those who are exposed to bacteria, the treatment to be given is called TB preventive treatment. That's the latter part of this one. That's the concept. So I want you to keep that in mind. Okay.